Good evening, everyone. Welcome to everyone here with us in person and those of you who are online. I'm Professor Frikkie Booysen. I'm the PPS Chair in Health Economics. The chair is based in the School of Economics and Finance in the Faculty of Commerce, Law and Management here at Wits University. And as part of the university centenary celebrations, we are having this very first panel discussion hosted by the chair. Before I introduce the moderator, I'm just going to say a couple of things about the chair. The PPS chair's main objective is, there are really three components to the chair's work. One of these is that there's a specific research agenda and research program run by the chair, and I will refer to some of the specifics of that agenda later. But it's really a multi and cross-disciplinary agenda. To understand health and its complexities, we need to learn from and lean on all the disciplines in the field. Secondly, we do work to build capacity. We have teaching programs because health economists are few, there's a shortage, and we need to do our bit in addressing that shortage in South Africa and beyond. Thirdly, and very importantly for me, is the issue of dialogue and engagement. And it's events such as this where we can engage with practitioners, with society, with NGOs, with other researchers to advance our work. One of the core focus of the chair's work is the work of the what is called the LELAPA Consortium. It's a UCL Wits funded consortium for work on family health and development. And men, of course, play a very important role in families. And that's why our very first, if you want to call it a dialogue tonight, is about men's health. And I'm very glad and privileged to hand over to our moderator, Skosana, from the conversation, and she will guide us the rest of the evening. Thank you.
Thanks, Frikkie. Good evening, everybody. As Frikkie has mentioned, my name is Skosana, and I am a health journalist. I work at The Conversation Africa. So today's discussion for me is so crucial. It's so important. I was reading some of the articles that we've published on our website, and just a few things, research shows that men are less likely to test for HIV. Furthermore, it shows that even when they are found to be HIV positive, men are less likely to access treatment. I've got a semi-first-hand experience of this. So I'm a health journalist, and over the years, I've spent a lot of time covering treatment drives. The one year there was a treatment drive at a very busy taxi rank, and I got to speak to some of the women in the line, because most of them were women. And I asked this lady, so why are you testing at a taxi rank of all places? And she says, you know what, I test wherever I get a chance. If they say testing, I test. I'm like, why? She says, my husband doesn't test. So he says, if I'm okay, then he's fine. And her husband is a truck driver, which is also one of the key populations who are at higher risk for HIV. But this man is essentially using her as a proxy. And I think this might be like at the extreme end of the scale, but it shows the danger, I guess, of this behavior. It does not just affect the individual, it really does impact on the whole society. So the panel here today are the actual experts, and they'll be able to tell us more about the hows and whys of it all. I just want to quickly go through and introduce everybody, and then we'll get it started. So immediately to my right is Justine Lacy. Sorry. She's a clinical executive with Profmed. And next to her is Dr. Yandisa Sikweyiya. He is a researcher in the Gender and Health Research Unit at the Medical Research Council. And next to him is Nomhle Soni. She is a trainer in community education and mobilization unit for Sonke Gender Justice. And that dashing gentleman over there, I'm sure we've all met by now. So thank you very much. Yandisa, you've done a lot of research on the health-seeking behaviors of men. Could you please just talk to us more about this?
Sorry about that. Thank you very much, Ina, for the warm welcome, also to Frikkie. I think this is a very, very important topic and dialogue to have as academics, people who are working with men in NGOs, because indeed healthcare avoidance is a really, really big problem in South Africa, in the region, sub-Saharan region, and this has been really confirmed and shown by the research that we've done with men in South Africa, for example. It is a really big problem. Men are not, seeking health care when they are sick. And I think I'm gonna really touch on the reasons for this. And we've conducted indeed in a lot of research as the Gender and Health Research Unit of the SAMRC, working with men to really try to link and retain them in care, be it HIV care or TB care, and other really health conditions. And what we have found, for example, with the research that we did here in Gauteng and also in KwaZulu-Natal, was what you are actually saying is very true, that men use their female partners as proxies. And they told us in the qualitative studies that we did in Gauteng and also in KZN, that they would allow or let their female partners, be it wives or girlfriends, to go and test. When they come back, telling them that they are HIV negative, and then they will assume that they are also fine or negative. And this was regardless of their own behaviors, sexual behaviors and all that, but they would use, their female partners as proxies for testing. But many of them, actually an overwhelming majority of them, told us that they only engaged with care when they were very sick. And these were men who were living with HIV. And they said that they only went to a health facility when they were very sick, and not in their own accord or free will, but when their partners had threatened to leave or had really handheld them to the health facility. And they were already sick, and their outcomes were really now is somewhat, risky in the sense that they were already very sick. But however, for us to be able to come up with interventions to work with men and bring them to, health services so that they can seek health and be able and be linked and engaged, we need to understand what causes them to stay away from healthcare. And there are a number of factors that are causing this. I will talk about some that we have learned from men themselves. One being masculine gender norms, where men who really ascribe to traditional or idealized masculinities, what we call hegemonic masculinities. Those men who want to exhibit themselves or that they are strong, that they are always physically healthy. They will try to avoid displays of illness, weakness, or vulnerability. And also we know that in many patriarchal societies, boys are socialized to with the notions that a boy does not cry, they must be strong, they must not show emotions and all that. And all of these things, when they are injured, when they are sick, when they have symptoms, they try to show this boyhood or this masculinity that shows them they're strong and healthy. But there are also other factors like health service barriers, for example. where health facilities are perceived by men as female spaces, and this as well is, implicates these masculinities that are traditional or hegemonic, in that men don't want to go into spaces that they perceive to be female spaces. They don't want to be treated by a female healthcare worker and all that. But they also, men talk about the fact that because they are providers in their families, they have to go out and look for work and earn an income. They find the clinic hours or facility, health service hours to be unfavorable for them, because they can't. During the day, they are out there looking for work to earn an income and all that. So they find that they can't access health. But also, this idea that a man has to provide for their families. Men who are, who ascribe to this traditional masculinity, they go out, they compromise their own health, they, relegate their own health, and say it's less important than finding food and money to provide for their families. So they would prioritize that. So those are really the issues. And as I indicated earlier on, is that there's an importance to find solutions to really bring men on board. And there are many programs that, that are out there that we can tap on. For example, like we have developed, interventions as the South African Medical Research Council, that we are hoping that we will eventually test, and hopefully if those interventions, those gender transformative interventions are showing effectiveness, then those can be scaled up and implemented to bring men on board. For example, like we've seen that intervention that we developed and pilot tested in Gauteng and KwaZulu-Natal really did show promise. Men who participated in that intervention really were, stayed in care. They talked to us about having remained as a group long after the intervention had ended, and continuing to engage with care, continuing to go out to communities and mobilizing other men to, to present in healthcare facilities much earlier before they are sick. And also we're working currently with young men in higher education institutions, young men whom we've spoken to, and they've told us that as much as they are, services within the universities, because of the masculinities that they ascribe to, they don't access those services. So we're engaging with them to really support them to construct health promoting masculinities, so that they can see healthcare as seeking as a way to be strong, and to be strong for themselves and strong for their partners and everyone. So we're working with these interventions, and I'm happy to expand more on those at a later stage. Thank you.
Thank you very much, Yandisa. And when you talk about interventions and so on, I think a lot of the time it's a flaw, I guess, in our health system, is that we're always looking at the curative, and we are treating people when they're ill, but preventing illnesses and screening for illnesses is just as important, and not doing so has catastrophic consequences. Justine, you know all about this. Can you tell us more?
Thanks, Ina, and good evening to everyone. Thanks so much for joining us. So I will touch on more of the clinical side of things. And I'd like to start by saying that I'm sure that you've all heard the adage, prevention is better than cure. So what if I change that wording to early detection is better than late diagnosis? Because we all know that prevention is certainly first prize when it comes to one's health. And there are many diseases that can be prevented or effectively controlled through the early stages, if not prevented completely from occurring. But unfortunately, there are many chronic diseases that one has no control over. You develop them no matter how careful you are about your diet, exercise, stress management, and what's actually important is the early detection. That's where early detection comes in. So When disease is detected early, treatment can be rendered timeously, and this essentially prevents extensive and often complicated and costly treatment that more times than not is associated with a late diagnosis. So there are other benefits to timeous treatment along the lines of minimizing pain and suffering, anxiety and depression, and other emotional effects that come with a diagnosis like cancer, for instance. And you'll also find that early treatment results in better outcomes because we're able to catch this at the earliest possible time. So I'm not sure how many of you are aware that prostate cancer is in actual fact the most common cancer in South Africa amongst men, and actually the whole world over. And 1 in every 15 men, according to the 2019 National Cancer Registry, will develop prostate cancer. So that is quite a scary statistic. And what's even scarier is this type of cancer can develop without any symptoms, and the symptoms will only show at a much later stage of the disease. So we found that men are testing late, which places them then in a position where they often have no choice but to undergo extensive surgery and cancer treatment. So if you look at this from a private healthcare perspective, medical schemes, every medical scheme that I can think of out there, actually offers preventative care benefits for their members. So, and I wouldn't actually be surprised if I had to ask you what comes to mind when you think of men's health. I wouldn't be surprised if you said prostate cancer and high blood pressure. Those are 2 of the more common answers that come up. There are also several other conditions, believe it or not: depression, suicide, high cholesterol, diabetes, and even malignant melanoma of the skin, which is more common in men. So, as I indicated, medical schemes are certainly placing a lot of importance on preventative care, and how they've structured their benefits around this allows for all members access to annual screening for their benefits. And this annual screening would be along the lines of the chronic diseases that I've just mentioned, which are cholesterol screening, blood sugar screening, HIV, and because we're talking more around men's health this evening, your PSA testing, which is an annual benefit that men should attend to from around the age of 40. So promoting primary health care benefits in the general population, as you can imagine, then is of the utmost importance, and people should be encouraged to practice vigilance when it comes to their own health and be proactive in this case. And neglecting one's primary care testing would certainly result in dire consequences. So let's take PSA testing as an example, seeing I've mentioned it already. So we already know that this type of screening should be done from the age of 40 on an annual basis. And if you look at the Profmed reporting, which is my reference point, we are finding that the average age of individuals testing is 65. And the really sad thing is that the reason why they're testing is because they've developed symptoms. So you'll find that maybe they've their pattern of passing urine has changed. They go more frequently at night, or there might be blood in the urine. They've picked up on something. They've gone to their doctor, and the doctor said, you need to go for a PSA test. And then, unfortunately, it's at that point where the cancer's picked up. And this may still be at a fairly early stage, and it might be localized, in which case they can go for a prostatectomy. But if it's a much later diagnosis, it could well have spread to other parts of the body, and that obviously would be of a huge concern. So Profmed, like most other schemes, has a preventative care program. We're committed to members' well-being, And this, along with regular communication, encourages annual screening amongst our members. So just to end, I want to say once again, rather emphasize the importance of annual screening, and to please take yours seriously, yours and your loved ones. So for the ladies in the room, please speak to the men in your life, and for the men in the room, please also speak to the men in your life. And in addition to this, if your body shows any deviation from the normal, please go and have it seen to. It's highly advised that you seek help and have it checked out, because rather get the assurance that everything's okay than ignore it for too long and be faced with the burden of a diagnosis that could change your life as you know it. Thank you.
Wow, Justine, I feel like you were talking to me, hey? Yes, but thank you. That is so important. We'll come back to you. Nomhle, I want to pick up on a point actually that Yandisa raised about bringing men on board. I suppose that is part of the things that you have to consider and do in your work around the men's programs at Sonke.
Good evening, everyone. Yes, as Sonke, we have a program called Brothers for Life, which runs in Soweto, Alexandra, KZN, 2 sites, Eastern Cape, 2 sites. So we do encourage men to live a healthy life, and we do ask questions. So what the doctor said, I do echo it, because when we ask them, they don't want to test because, for example, you are seen as weak. They don't want people to see you in the clinic. They're going to start talking about you. So the best thing is to send your girlfriend. The best thing is to change girlfriends. Maybe she's the one sick. I'm not sick. It's not possible. And they don't have time to go to the clinics. They see the queues and they say, no, they must go work. They can't have time to stand around in the clinic. So we bring them around and they say, what can the health facilities do to better you coming in? And they said one of the things that scares them is that most of the people in the clinic, the workers, the staff, it's female nurses, and they can't have their private parts being seen by a female nurse, especially in the area that you live in. That nurse might be your neighbor, or you take the same taxi, you commute, and she knows your private parts, so no, they won't do it. They'll rather die. And we say, well, that's a bit extreme. So in us questioning them, they said maybe if there could be more males, that's a male section within the clinics where they can go in and out quickly. They want something made easy. They don't want to stay in the clinic. Another thing that they say is if, again, you are seen in the clinic, you're weak, it's better if you go the traditional route. So that's more for the black males. It's better if you go to the traditional doctor. That works better than the Western medicine. So they go there and we ask them, but why? Because sometimes, you know, the dosages, they don't follow to the core, and it ends up causing more damage to their bodies than doing good. They said that's what their forefathers were doing. So a lot of things which also prevents them, it's tradition and culture. It's saying my tradition doesn't allow me to go in the spaces where there are lots of women, especially we found that in the rural KZN area. So, and also saying, let's look at churches. They also have a big impact in saying now, men don't go to clinics. Come, let's pray for you. Let's pray it away. Instead of educate, we need to educate our pastors, our reverends, of saying, in your men's forum, talk about health, talk about the good of it. Early detection, as you said, is the key. They would rather stay with the pain so they're not can be seen as being weak. And then when he's not waking up from bed, only then he will say, take me to hospital. By then you're in stage 3. This thing could be detected on the early stages, you see, and they don't want to say, I'm weak, I'm vulnerable, please help me. They rather say, you know, if I go for a drink, it will go away. Not seeing that's only a temporal measure. In the morning, again, you still will be sick. And again, if it comes from the wife, it does not sit well. Rather, his brother comes, say, listen here, my brother, I think it's time for us to go. Only then he will listen. Or if his son tells him to do it so. But if the daughter comes in, it doesn't listen. So part of tradition and culture has a negative impact. That's what we must look into, and we must try and change harmful cultural practices, which leads to, you know, men dying at the early age. And we also, I want to concur what the doctor says. Even young men don't want to go into varsity facilities, healthcare facilities, because again, they're gonna be seen as weak. It's better maybe if he goes to a private doctor away from the campus, so he won't be seen. It's better if again he asks the father, Dad, this is wrong with me. So now if a dad has this mindset, he's also gonna pass it to his son. So that's what we have found out. And so we are having meetings and saying, what can we do to make it easy? What can Department of Health do to make it easy? And so we're having those conversations, and I think the results will come next year of our findings of why and how can we help to change the mindsets, because you cannot force the horse to drink water. You see, it must come from them. When it comes from them, then they listen. Thank you.
That's very insightful. Thank you very much. Now, another part to this conversation is obviously the importance of research and ongoing research. Frikkie, could you please just tell us more about the work that you're working on?
Thank you so much. I'm going to talk about 3 things. I'm firstly just going to very briefly talk about some of the findings in the literature. I'm going to then talk about the consequences, and in particular the economic consequences of avoidance. I'm going to spend a little bit of time talking about where research should be going in terms of addressing this issue, and then I will conclude very briefly. In terms of the key findings, there's a multitude of reasons, and Nomhle and Yandisa noted a number of these explanations for avoidance and predisposing factors. The one that's not been mentioned, and so it's complex causes that interact with each other. The one that I've not heard as explicitly mentioned is mental health and psychological distress, and the literature suggests that it's a major influence or cause of avoidance. But it's even more of a problem because avoidance influences your mental health. So there's a vicious cycle going on in terms of avoidance and mental health issues in men. How big is this problem? The answer is we don't know in South Africa what the magnitude is. Many studies here and internationally study men that do engage with the health system. So it's not a general population survey that assesses the prevalence of avoidance. In developed countries, the survey suggests that it's between 25 and 30%, which is a sizable number. It's likely that it's higher in our society simply because many of the predisposing factors are more severe and are more prevalent. But we need to know what that number is, and I'll speak a little bit about research. The consequences are important. They're not documented, they're under-researched. At least in my research, I couldn't find much work about the consequences. What are they? There are issues of absenteeism and presenteeism in the workplace, and obviously those raise productivity issues, loss of economic output. But there are also opportunity costs for patients or for the sick, for their families, for the public fiscus, because we, on the one hand, as Justine mentioned, we are having to treat illnesses much later when they're much more severe. So that's a very large opportunity cost. Secondly, we're talking about premature mortality, which has got a lot of economic implications. So there are important opportunity costs. But to me, the social cost is really maybe what is the greatest in magnitude, because society is being robbed of men fulfilling their roles to the maximum by being ill, by presenting late with illness, and having mental health issues. So I think there's a significant social cost that we need to speak about. We need to speak about men and their role in society. And as I mentioned, this is really undocumented and under-researched, which brings me to just a couple of points about research going forward. First of all, data matters. We need a number. We need to know what the magnitude of the problem is. We need to know its determinants, not only in at-risk populations, but in the general population. We can't address something if we don't know the extent of the problem. We can't invest in interventions if we don't know what those impacts are, what the costs are, what the cost effectiveness is. And it's encouraging to me that the research that the people around the room are doing is addressing those issues. And that is very important. Science is important. We need multiple views, multidisciplinary views. We need to apply our collective minds to the issue. Context matters. So yes, we need to know who the at-risk populations are, but we need unique solutions. We need solutions for the South, which in many ways are quite different from the northern countries. I also want to make two additional points, having listened to my fellow panelists. So one of these is that we should take a holistic view. So yes, we should worry about specific diseases. We should treat, but general preventative interventions are important. Health promotion is exceedingly important, but we should also talk about equality and equity. It's wonderful what medical schemes do, but for most of men, access to medical schemes are outside their reach, and we need to think about, and as Nomhle is saying, we need to talk to the Department of Health and have a conversation about how we reach all men. But to conclude, if all men are in good health and well-being, we can leverage their potentiality, all men's potentiality. And that is really important to achieve the development goals and aspirations that we set ourselves. So I'm looking forward to more conversation, more exchange of ideas, and making researchers make a difference. Thank you, Ina.
Thanks, Frikkie. Let me put you on the spot. You say that you want to see researchers make a difference. What at the top of your mind does that look like on this particular issue?
What it looks like to me is not only doing your research in an isolated corner, but engaging in media, engaging in social media, translating what you're doing to all audiences so that all audiences can understand what you're saying. In other words, not speaking as an academic, but speaking as an activist. We should be activists.
You really just made the science communicator very happy. Thank you. Nomhle, I wanted to ask about the work you are doing. Sorry, what do you guys intend on doing, or what do you do with the information that is gathered through your interactions with these men?
Okay. First of all, when we find our findings, we go back to the community and give them the findings, because they're part of the study. We give them the findings, and then we engage with government and in saying, this is what we found on the ground. These are the results. Can you please make a difference? And we talk about the way forward. When is this going to happen? They give us their timelines, they take it in, and then if nothing is done, so we have evidence of saying we've submitted this to you. The stats are still high, nothing is going down, that means you didn't take us seriously. Then the next action takes place and saying, okay, let us protest, let us show them that we're serious about this issue. We collect evidence and then, take steps forward. And again, with the mental health issue, Frikkie, we recently had a mental health day in Diepkloof, where we had, I think, about 100 men from different wards within Diepkloof and Orlando to say, let's talk about mental health. Only to find out, after that engagement and dialogue, because we had experts, as they were telling the men about simple symptoms and things that people do. Sometimes they even lead to GPV and femicide. They didn't realize that they had mental health issues. We had cases coming out of the dialogue, which are very serious. We referred people to psychologists, to social workers that we work with. And we're saying to ourselves, no, literally, we need to go back and go deeper into this mental health issue, because as Black people in the location, when you say mental health, all they think is you are mad. You are just going to the loony bin very soon. But it goes deeper than that. They need to talk. Men don't voice out their issues and their problems. They rather stay in their corner, and then when it bursts out sometimes as GPV, as I said.
Yeah, they lash out, not voice out.
Yeah, they just lash out in anger instead of talking about it. So we can find solution with your partner or with the person that's helping you deal with your mental issues. Thank you.
That's very important. Thank you very much. Yandisa, I wanted to ask, you mentioned some of the drivers of healthcare avoidance, or some of the factors. So what I wanted to know is, were the reasons similar across the board, like across all socioeconomic status? Or, were people in the suburbs more prone to a different idea, a different view?
Thank you very much, Ina. That's a very important question about really what these drivers are. So for example, with the driver, like men's constructions of masculinities, for example, and men's, belief and about their role in society being that of being a provider. I think that is a factor that cuts across social classes. All men want to, they ascribe to this traditional or hegemonic masculinity, or they idealize or aspire to it. And they want to do that, and they believe that they are busy. They believe that they have to go out and find, earn an income so that they can, provide for their families. But with what Frikkie was saying, there is very little research that has been done in this area, and we really need funding to do this work so that we can really build, have strong data that we can use as base to develop, health promotion programs to engage men. In these programs, it's important that we focus on primary prevention programs, for example, so that we can ensure that men do link and engage with healthcare before they are sick. They know that if they feel that there's a pain in my knee, I need to just go in and have it checked. We need to make it fashionable for men. And what Nomhle was saying about awareness, community mobilization and all that Sonke is doing is quite critical for that aspect of really making men to really see health seeking as a particular trait of their masculinity. It's proper manhood, if you like, if I may say that. But also for those men who are already sick, it's very important to have secondary prevention interventions. And those are the interventions that I spoke about, for example. Like in a study that we did in selected higher education institutions in South Africa, we have found that there's a lot of a big problem of poor mental health amongst men. And what Frikkie and Nomhle was saying about the fact that there are these problems, they are not seeking health, and also mental health does have implications for their help-seeking behavior. And we need to engage with these young men to really help them to come out of that and be able to be linked to care. To answer your question more pointedly, research that has been done is mainly done in working class, poor black men. That is what we've done. But as Frikkie had said, there's little research. I would like to emphasize that we need to do more work, more research in this area, so that we can really understand the magnitude of the problem, as he said, and therefore we can be able to prevent and respond to it.
Thank you very much. You made me laugh when you talked about the Soni. My dad had a Soni for the longest time, and after threatening to never talk to him again, he eventually went to the clinic, and he went with my sister-in-law, and whatever they told him got him so hot or under the collar that he left her at the clinic. So I'm like, what happened? He's like, they tell me I've got hypertension, high blood in my foot, what's the and he just never went back. So no, I mean, we still have a lot to do there. But Justine, I want to talk about the role of private sector. We talk about the need to communicate and make people aware of what's around and what's available. So what role does private sector have in making sure that people, not just their members, know and have aware that you need to go screen for this and you need to go do that?
Yeah, so I mean, once again, if I can talk for Profmed, we are quite big in the media space. So I think we use social media to get to people who are more than our members. And what we do is focus on topics that are hot, topics that are relevant. We actually write articles on topics of relevance that we feel people can benefit from. And we will always use October to mark Breast Cancer Month, November, Movember, Men's Health. We've just come through a whole design around mental health and how we can use that in the media to promote that type of benefit across the nation.
Perfect, thank you. Do we have questions? Where's Tulwana? Okay, thank you. Do we have questions in our audience? No questions yet. That means we either are very boring or we've answered everything and no one has. Frikkie, I wanted to ask you that in looking towards the research going forward and trying to plug the gaps, are you considering gender diverse people?
Are we considering gender diversity?
Yes.
Yes, that's very important. It's something we're not. When you in a survey collect data, you collect data on sex, not on gender. One of the exceptions is the Gauteng City Region Observatory's Quality of Life survey that actually in the last round asked people about their gender identity. and they could identify as male, as female, or as binary. And that's the type of information we need. So any program that speaks to men needs to speak, we need to speak about men, people who identify as men. That's, I think, the correct language. So yes, we shouldn't, in our work, we should look beyond sex to gender and issues of gender. And I think what both Nomhle and Yandisa spoke to was how this is in part tied to GBV, it's tied to masculinities, it's tied to issues of gender roles and norms. So yes, I mean, we need gender-sensitive research. And I believe there's now speak of gender-sensitive budgeting in the province, I believe. So, but yes, it's something that we all, and in this topic is very important. You know that there's a lot of research about how spouses' health are related and highly correlated. So the way to many men's health would be through their partners. And so we can't have this discussion without having a discussion about gender in terms of everything that gender entails.
That's a very good point. Nomhle, I wanted to hear from you. What's the role of women in this discussion?
Play a very important role because they know the ins and outs, especially of their partners. They know the excuses, they know maybe what to say at what time, especially with your partner, to try and convince to go to a health facility. And also with the groups that we have with Brothers for Life, men do tend to say, you know, for this type of question or this questionnaire, we need women to come in because they will have a better answer, because some questions they want to take back to women saying, we're doing this because of you. So as much as it's focused on men, women are a big part of it as well, because we need women to be there to answer on the spot, saying, here are men saying they're not going to the clinics because they must work and put food on the table for you. How true is that? You know, a woman will come through and say, but that's not true. I work myself. You know, we work equally. So women are much important in this conversation as men are. We must try not to separate as much. We might have different groups, but along the conversation, women must come in. Along the conversation, we must look at young, upcoming men. So we look at boys, we look at saying, let's break the chain now with these boys. Let's break this chain of thoughts that's been inducted in their brains is what a man is, what a man must do when it comes to health. So again, we have a group of older men and young men that say, let's have a conversation. What does your uncle say to you? What does your father say to you? And then they have a conversation, and going back home, they look at their situation and saying, I've been preaching the wrong word. Let me tell my son, no, it's fine to do this. You know, sometimes they say, no, for me, it's too late for me. Go to these young boys. We say, no, it's not too late for anyone. You are the teacher now, because I'm not going to be in your household. Take what you have learned here, take it to your nephew, take it to the young boy on the street and educate. Thank you.
Yandisa, what does a responsive healthcare system look like when we're dealing with the issues of men avoiding care?
Yeah, that's a very good question. I think for me, a responsive healthcare system should really be a healthcare system that is really keen to understand why men stay away, and one that really makes effort to go out of health facilities and link with community-based NGOs that are working with men to ensure or even to facilitate men's access and linkage to care. One example that comes to mind for me with a very, very good partnership between health facilities and community-based organizations that work with men is one that is implemented in Gugulethu in Cape Town by an organization called Movement for Social Justice and Change, which is an organization that has a men's forum in it. And they have really forged very close linkages with clinics in Gugulethu, and hospitals. And they are able to, healthcare workers from the clinics and hospitals are able to go out and engage with men in that men's forum. And we saw the research that is coming out, the findings that are coming out of that program are really, really very promising, very encouraging. And those are the models that we need to really evaluate and replicate throughout the country. We know that in other instances, there's talk about men's clinics. And we need to really understand those models and see what they work. Because, for example, in Gugulethu, they have a men's clinic, but we also know that, that could bring issues around health equity and all that. And also, whether we should test whether really this notion that men will come and engage in care if there's a male healthcare worker, for example. We need to understand that, and that it speaks to what Frikkie was talking about, because we also know that men who ascribe to traditional masculinities, when they are attended to by a male healthcare worker, they are likely to want to show to these other men that I'm strong, that I'm not sick, that I'm not weak, and all those things. And some men, for example, in the research that we did, spoke about being freer or more comfortable to speak to a female healthcare worker. So I am saying that we need to do a lot of research, because things, as Frikkie said earlier on, they are very complex, these issues. So we need a healthcare system that really uses a primary healthcare approach, go out of the facilities, go and engage with men, understand how they can bridge the gap between men in the community, and be able to engage with them there, and then they will be able to bring them over to the facilities and all that. And for example, in one hospital in Gauteng, south of Gauteng, they spoke about going to men's forums and men's groups and testing them there, and taking their CD4 counts and all that. While in those forums, that was a good model, which I believe can be tested and replicated if we see that it produces positive outcomes. Thanks.
Frikkie, I want to ask you about the cost of some of these programs. Is it feasible for us to have community health workers walking up and down and trying, and everybody has an iPad, and we need, is it feasible to try to take primary care levels into the community and go test people where they are and things like that?
You sprung one on me, but let me answer it in this way. There's a lot of community health worker research that suggests that those programs are in fact effective and cost effective. In our country, we need to think about whether it's sustainable and not only effective. I think they can work, and they do work. There's a lot of evidence that they do work, and they've worked for many years. But how we use them to address the problem of avoidance is the question now. How does a community health worker engage with men in a community. And they're not exclusively female, but many are female, so these same issues come to bear. But I think we need to think about, and my understanding of current existing community health programs is that healthcare avoidance in men is not a focus of those programs. So the question about programs on interventions for avoidance is, as I've mentioned, I haven't seen any costing of any such programs. But while I have the floor, something else I just want to emphasize is that it's very specific that we chose the term avoidance, because there are other terminologies. There's engagement, there's delay, there's retention in care, there's adherence, there's help seeking. A lot of the research only study people, or men in this instance, when they engage with care. And my concern really is with the men who never gets there. The men who dies of prostate cancer at age 50 or 60 or 40 that could have been treated. So I think it's important that we focus on avoidance as at a methodological, conceptual, terminological way, and distinguish it from these other terminologies that we use, and that our research engage and interview men in communities who haven't engaged with care, who never engages with care. But I don't know if I answered your question really.
No, you definitely did. I think the thing that keeps running around in my mind is that it's a double-edged sword. It's the attitudes of men, and it's to some degree, but you also cannot deny their concerns about healthcare facilities, about the fact that it's very maternal-centered, and there's very little room for privacy, and obviously very few male staff. And it looks like if one wants to address these, you have to look at both sides. Go ahead.
I would agree with what Yandisa said earlier, in that I think it would really make a difference for consideration to be made to have more male healthcare staff available at these facilities, so that they can meet men on men's needs. Just as from a woman's perspective, if you go, and this is with all due respect to male doctors, but a woman going to a female doctor about female problems might get more sensitivity from that female doctor. I mean, it's a huge generalization, but it's just a hypothetical example. So I tend to agree that, from a resource perspective, that's an important consideration.
Sorry, Frikkie. We have a question. Where is it? Oh, hi.
Okay. Greetings, everyone. I think these are very important conversations that we need to have in society. But yet again, the main narrative from what I'm getting is that we're speaking about women, we're speaking about men, but how far are we able to assist foreign nationals? Because we all know the narrative, that I can't get medical assistance because I don't have this, I lack that. So how far are we able to help these foreign nationals? To what extent? Do you understand?
I think you certainly raise an important issue, but I think what is important to me is that all men should matter, including foreign nationals or other. I think what's important in what you say is that they at particular risk because they may not have the same access to healthcare. And it raises an additional issue of how do we address avoidance in those specific men. So what we really need to do is we need to understand who the populations at risk are and what interventions do we design for those populations at risk. Because those interventions may be very different. And maybe I forgot the one point I wanted to make. There's actually, some of you may and some of you may not know that there's an integrated strategy for men's health 2020 to 2025. There's an actual strategy document, and if you read the document, it seems like a lot of, as an economist, we would call them supply side interventions. You know, have services for men, train our healthcare workers well, and there's not a lot of talk about interventions on the demand side. How do we change people's perceptions or behavior in terms of wanting to engage with healthcare services? But you raise a very important point in terms of a very, I think, specific population that is at a high risk and where avoidance is a very important issue.
I mean, we are also seeing similar research being done among women, where there's specific research looking at migrant women and how they access prevention of mother-to-child transmission and looking at cross-border migrants versus internal migrants. So I do think that our health researchers are cognitive of that. And it is something that is being looked at while the research is happening. And the good thing about that is that if it's in research, hopefully someday it'll make it into policy.
Thank you.
Yes, that's the mic. Please just tell us who you are.
Okay, good evening. My name is Sutukazi Mabona. I am a psychotherapist. I work here at Wits University. By profession, I'm a social worker. I've been in the mental health field for about, 10 years now, and I've been working with students. And I started embarking on a research. I was quite happy, Frikkie, when you were saying that we need to be talking more on the avoidance. I liked that word because there are men who have not been reached. Because even me, as I'm trying to do my study, I know my head would bounce on how am I going to get the participants, which is the men who have not set their foot in any health facility. Do you understand? Especially with university students, how am I going to do that? So I think it's a very important factor that we need to look at. However, I just wanted to ask Nomhle and Yandisa. There was something that you mentioned, Nomhle, about culture. You know, you've talked a lot about that. And when I looked at some of the work that was done, especially by Bunches and some international writers, when they suggest that we should have targeted outreach programs that would encourage male to seek treatment with a focus on a more cultural approach, you know, a culture-sensitive approach, a culture-sensitive assessments when we are dealing maybe especially with mental health, because for me that's the field that I have an interest in. But just wanted to check that maybe in the work that you do or in the research that you have done, maybe the studies that you've piloted, have you been able to probably establish that? And number two, looking at South Africa being having diverse cultures, how can we come up with a universal approach, or a local or national approach that we can say if we are being cultural appropriate, what works for a Zulu man might not work for a Xhosa man, what works for a Swati man might not work for a Sotho man. So I just want to check that what have you put in place? I'll put, for example, the issue of traditional healers. Now in mental health, we are looking now at an issue of if somebody says, I don't have a mental health illness, I have a calling, and I prefer that the Sangoma can be here with me. And how do we dismiss that? Do we just say, no, you are not having a calling? Or is there a way that the psychiatrists can work together with the traditional healers? Yeah. So I just want to check that in the work that you've done, is there something of that nature that's there?
Definitely there is, because we do have sections of saying culture versus tradition. How does tradition influence culture? So, because in Gauteng there are different ethnic groups, we are looking at saying, let's go to the hostels. Let's call Induna because they listen to him. So if we sit down with the leaders and say, look, this is what is happening to your nation, how can we bring about change? So if you talk to the leadership of these cultures and traditions, they're more likely to listen. However, it's very hard to make an appointment to approach those spaces. You have to, even though let's say you are a head of a research, but you are a female, it's very hard to approach Induna. You have to go with your male partner and dress in a certain way and tell your male colleague and say, this is what you're going to say. And you are not allowed as a male to turn back to your female colleague and say, what do I say now? So you sit down, you think about the question, think about the environment. We have tried, we're in a process of meeting Induna. They came once, and then the second time they invited us to a hostel. And it was a very hostile environment. So we're trying to take them away from their comfort zone and saying, let's meet in the central area. So let's discuss. So it's a bit of a tricky situation in terms of culture and tradition. It must be handled with very soft gloves, but at the end we are going to win because now we have, I think, the 3 hostels that are willing to engage with us. We are having to say in Eastern Cape, they're making appointments with also the leaders, the traditional leaders. They're making leeway, slowly but surely. So for now, we're saying, once all the provinces have the leaders of these cultural people, we're gonna say, let's meet at one place. Let's talk about the traditional harmful norms that are there, that's affecting our male. Let's look at, especially again, mental issues, which we're saying if a person, for example, is hearing voices, that doesn't mean that the ancestors are talking to him. It's person needs to be referred somewhere. So how can we bring the Western medication and the African medication together? Like in KZN, they have such a program where, for example, in Edendale Hospital, there is traditional healers within the hospital. So you go there and then they say, okay, this is an HIV case, this needs psych, this needs a social worker, and you get a referral letter within the hospital from the traditional healer to send you to the doctor. So again, if you go to the doctor first and they see that you're that traditional person from the rural areas you hear, they will give you medication, and then for your peace of mind, they will send you to the traditional healer. And the traditional healer will convince you, say, you must take these medications as they say, so you're gonna be okay, and then they go out feeling better emotionally and saying, I've seen the doctor, I've seen the traditional healer. So we're trying also to have that conversation with the leaders. Thank you.
Thank you very much, Sutukazi. I think you are raising a very important question, and I would imagine that it's important even for your, practice, yeah, and it's equally important for research. It's equally important to really understand the role of culture in people's behavior, and in our situation here, men's avoidance of healthcare. And I think that, we know that really cultural norms and values are really very important factors that drive how men behave. Because men knows about these norms and they want to adhere to them. They know about the values that are attached to what it means to be a man, or how men are expected by their society to behave, and they want to adhere to those norms and values. And therefore, an intervention that does not take those into consideration is likely to fail. So what we do at the MRC, for example, when we are developing interventions with men, for example, and also with women, and we are developing an intervention in setting X, we, as a first stage of our intervention development, we do, of course, literature review to understand what has been done in other areas. But what is most critical is doing a formative qualitative research where we explore these issues around culture, cultural values, cultural norms, and all that, and really do a qualitative analysis to understand how men hold these values and how significant are these cultural norms to these men, so that we can use those as an entry point in engaging with men. So I just want to say that it's, for us, we always talk about cultural appropriate and context-specific interventions. So which means that we are making a claim that this research that we are doing is really rooted in the social context and cultural norms and values. It has taken those into consideration. And therefore, as we are building the intervention, those things are incorporated. And they are likely then, if men feel that their cultural norms and values were considered, and they feel that they have constructed this intervention themselves, and they are likely then to latch into it and believe in it and adhere to it. So I think it's a very, very important point. Thank you for raising it.
Thank you. Tulwana, we good? Okay. If there are no more questions in the room, I'm going to just ask everybody probably the same question, and then we wrap it up. I promise, last one. I was looking at the panel, and one thing I realized is that we do not have a government representative here. What's the role of government?
I think for me it's quite important, Ina. I think it's quite important to bring along, government in developing work, so that they can be partners in the work that we are doing. Because if you remember, if you could recall, Frikkie and also Ina, and we spoke as well about the importance of advocacy. The importance of not only doing research and leaving it at publications, for example, but also pushing advocacy work and doing another level of research uptake. And if you have involved government at an early stage, they are likely to have a buy-in of the programs that you are working on or developing or implementing. So it's quite critical, and what the lessons that we've learned is that we need to really ensure that we engage with them at a very early stage, because what we often do as researchers is we have in our publications policy implications, but But most of the time that those publications stay there and gather dust because we have not really engaged with policymakers, and we've really not really invested in ensuring that we have a working collaboration with them so that they can, the moment the results are out, you are able to go to them and engage and say, how do we take this work forward? Frikkie spoke about cost-effectiveness analysis that is needed after intervention has been proven to be effective, for example. And we need then to do that cost-effectiveness analysis and then be able to go to government to say, this program is effective and is cost-effective. And we talk then about scale up. Scaling up interventions that work so that we can have a greater reach, of men who are sitting out there and avoiding, to engage, to come to engage with healthcare. Thanks.
Thanks. I think working with government, it's quite important. You must not fight with government, but rather work with them, because government has responsibilities. Because we're talking about the National Strategic Plan now, the NSP, the big thing, 6 pillars. Good. Now, pillar 1 talks about accountability and responsibility. So government needs to be accountable, needs to be responsible. It also has pillar 5, it talks to research, which they must come in and be part of the research that's been done. Also, when you talk to government, for them to have a buy-in, you must be, as private sectors, NGOs, as NPOs, you must be careful of not letting your ideas go of astray, because they tend to overpower you sometimes. So you must be strong in saying, this is what we want, because we've done research, these are the outcomes, so we need to do this together. You need to be strong in saying, I've got this, like the doctor is saying, I've got this, this is evidence-based. So you need to look into your policies, and you tell them to engage you when they're writing their policies while you're still in the white paper stage, so they can get feedback from the ground, what the people are saying, so you can influence policies. We need to work with government to influence policy, and we need to say to our people, this is what we said, we have submitted it to government, this is the feedback they said, the policy is about to change, the president has signed on it, so people can have pride in the policy that comes out and say, no, we're part of this, we were part of this policy changing. They can own it as people and not say how a 12-year-old girl can go into a clinic and have an abortion. When was I told about this? We don't like it as people. So they need to engage with us because we work on the ground. So take it from the bottom up, mustn't come from the top down. So we need to work with government to change policies, influence policy. Thank you.
Thank you, Ina. I want to venture that where that co-creation is possible. And I'm happy to say that we recently worked on a project with the Gauteng government. It was a grant application, but we worked together in putting that grant application together. So I think government is important, and we should and we do involve them.
Thank you very much. Let's wrap it up. I can have this conversation all night, but I won't. Justine, final thoughts from your side?
Thanks, Ina. I just wanted to thank everyone for listening to me tonight. And if you have any other questions pertaining to anything clinical that I can answer on men's health, please feel free to contact me. And I just want to say, if it's one message that from me that I'd like you to go away with tonight, it's please just to remember to go for your annual screening, please. Thank you. Thank you.
Yes, I just want to thank, the organizers of this event, and for really putting this, dialogue and focus on men to the fore, because it is really an important, topic and a big public health and societal problem, and economically as well, in South Africa and in other regions, and I wish that this dialogue will lead to more work, in this area, and for the field, for the research to community to understand the significance of doing research and intervention work for men for their own health. It's quite important, and I take my colleagues' plea is to go for annual screening. It's very important. Yeah, I will do so. Thank you very much.
Okay, my last word. Firstly, I would like to thank all the men that are here for coming, listening to this conversation, because men don't like to attend such events. Yes, screen. Thank you.
Hashtag man up. Hashtag seek help. Hashtag speak out. Thank you.
That's it. Thank you, everybody. You've been amazing. And I believe we have some nice things out there. No? Which way is it? Okay, perfect. So we'll hang around and we'll mingle and we'll get to chat some more. Have a good evening.